Hello, everybody. Thank you so much for joining us. Welcome to a session entitled Anti-Blackness, Abolition, and Criminal Justice, a conversation with Dr. Emily Wang and Professor Tracey Meares. This talk will be followed by commentary from discussant Sydney Green. My name is Anna Reisman. I'm a professor of medicine here at Yale School of Medicine, where I direct the program for humanities and medicine. And I am absolutely thrilled to be co-hosting again with my colleague and friend, Dr. Helena Hansen, who is associate professor of psychiatry and anthropology at New York University. And for several years, she has been running the wonderful Social Medicine in Action series here at Yale School of Medicine. Tracey Meares is the Walton Hale Hamilton Professor and a founding director of the Justice Collaboratory at Yale Law School. Before she came to Yale, she was a professor at the University of Chicago Law School, and she was the first African-American woman granted tenure at both law schools. She's a nationally recognized expert on policing in urban communities, and she has worked extensively with the government, the federal government, including being a member of President Barack Obama's task force on 21st century policing. In 2019, Professor Meares was elected a member of the American Academy of Arts and Sciences. And some of you may have read her piece in The Atlantic this past June that was called "The First Step is Figuring Out What Police Are For." Dr. Emily Wang is an associate professor in the Yale School of Medicine, where she directs the Health Justice Lab and the brand new SAISH Center for Health and Justice. The Health Justice Lab is a collaborative, interdisciplinary team focused on improving the health of individuals and communities affected by mass incarceration. The SAISH Center will focus on identifying and applying strategies to improve the health of individuals and communities impacted by incarceration in Connecticut, nationally and globally. Dr. Wang has cared for many individuals with a history of incarceration, and she's also the co-founder of the Transitions Clinic Network, a growing consortium of 30 community health centers nationwide dedicated to caring for individuals recently released from correctional facilities by employing individuals with a history of incarceration as community health workers. After Professor Meares and Dr. Wang each offer brief remarks, we will hear from our discussant, Sydney Rose Green, who is a fifth-year MD PhD student at Yale School of Medicine and the program in History of Science and Medicine. Sydney's research uses intimate partner violence as a lens to interrogate histories of racialized and gendered surveillance in medicine. Following Sydney's remarks, we'll have plenty of time for your questions. And we ask you to use the question tab at the bottom of your screen, and we will take those questions at the end of the remarks. And with that, we will get started. Thanks again for tuning in.
Should I go? Okay. Good evening, everyone. I speak to you from my home office in New Haven, which in this very room actually was rated yesterday. Rate My Room. It's an interesting Twitter account. I got a 7 out of 10, so I'm wondering what you all think. I like it. I spend a lot of time here. I hope all of you are doing really well this evening under some very challenging circumstances. We have come together to talk about the criminal justice system tonight. I would like to point out before I start my remarks that almost everything that we have to say about issues concerning abolition, anti-Blackness, racism, reform, justice are actually a part, intimately connected with the experiences that everyone is having with the COVID pandemic. And that's a really critical thing to think about. I think when Dr. Wang, I'm going to call her Emily from now on because we are close friends and colleagues, when she speaks, she'll bring that home. But for right now, what I want to do is offer some framing remarks. And I really look forward to our dialogue later this evening. My remarks are going to point primarily right now to this concept of abolition in this moment. And to think about that, for those of you who are on your computers, probably all of you, I would point you to something that I wrote in the Boston Review in 2017. It was a piece about policing as a public good. And in that piece, I said that policing as we know it must be abolished before it can be transformed. And that might be an odd thing for someone who's a lawyer to say, someone who has worked so closely with government as I have to say. But I think it is absolutely critical, and understanding the connection between that term abolish and what I meant in the context of that piece is important. And this is what I meant. When you think about the term abolition historically, it is inescapable to the context of slavery is inescapable. And that's an important starting point, because one should understand when one is using the term abolition that, and historically, when slavery was finally abolished in this country, no one seriously understood that to be eradication, simply the eradication of the legal category of slavery. If that were the case, right, if all abolition ever meant was eradication of the legal category of slavery, then it would be okay to pay Black people less than it would be to pay white people, or to have a system of convict leasing, or to have a system that denied Black people the right to vote, or to have a system of segregation in which Blacks and whites had to sit separately, or maybe Blacks were excluded from public accommodations. Wait, that's what happened, right? And that happened because the 13th Amendment, which abolished the legal category of slavery, didn't do the rest of the work to establish full citizenship for formerly enslaved people. What did the rest of the work, or what was intended to do the rest of the work, were the other Civil War amendments. And those of you who are students of history know that even that wasn't enough. We needed Reconstruction at that time. And we had Reconstruction for a very brief period of time, for about 11 years, before white supremacist terrorism cut it short. But during that short period of time, those of you who are familiar with the work of W.E.B. Du Bois knows that Black people, formerly enslaved African Americans, were able to begin to work out the terms of their citizenship. And what did they do? They established schools, they established churches, they worked to establish nascent forms of healthcare. And there was a very brief period of time, and maybe Emily will speak about this, in which the federal government actually supported a very nascent form of public health care for formerly enslaved people. The point of understanding this is that the promise of Reconstruction didn't really ever take place. And here we are, over 100 years later, still trying to fulfill the promise of Reconstruction. I say this to say that it is impossible to understand what people mean when they say abolition of policing without understanding the history of abolition itself and the critical connection between abolition and Reconstruction. So when I hear the terms defunding, or when I hear the terms abolition, I don't simply think no policing or reducing the budget for policing and no investment elsewhere in any other aspect of government. What I hear is simply a call for people to fulfill the promise of Reconstruction that we have never actually fulfilled. This is about the set of public goods to which every citizen in this country is entitled. One of those public goods, of course, is safety. But in this country, safety has been conceptualized as a certain narrow form of policing comprised of sending armed first responders to people calling for emergencies. When you ask people what their conception of safety is, and in particular, when you ask people who are living in places of concentrated poverty, the same places that experience high rates of infant mortality, high rates of comorbidity for coronavirus, the same places that are experiencing high rates of coronavirus exposure and so on, poor housing, food insecurity, etc. Also, these are the same places that experience unbelievably high rates of criminal legal system exposure. They will describe what they want in terms of safety, not in terms of how quickly can an armed first responder arrive to their home, but they will define it in terms of what kinds of supportive services can they get before these issues that they experience turn into high rates of violence. They will ask for better education. They will ask for better housing. They will ask for much better access to public health care. Those are all critical aspects of public safety that people don't get. And what they do get, as I've mentioned before, is an armed first responder. So it's critical for us to understand that when we're talking about the set of public goods that each citizen is entitled to, that is at the center of this conversation of defunding, even though the catchphrase has been defunding, because it's simple. And that's what's going to get people out in the streets. But importantly, it is not what's going to get us from here to there, right? Another way of understanding it, and then I'm going to turn this over to Emily to, make things a little bit more concrete, is the phrases defunding and abolition are compasses. They point us in the direction that we might want to go, but they're not a roadmap for how to get from here to there. And that is the work that we need to do. And that I'm hoping that those of you who are listening in on this webinar, especially those of you who are working in the healthcare industry and medical students and the like, can be dedicated to and devoted to. Thank you.
Great, thank you, Tracey. It is a real deep honor actually to be sharing our 6 o'clock hour together with my good friend, and also to have this conversation. It's a conversation that I welcome and entertain, and realize that there's a disparate kind of views in our medical community, but in particular, I think that perhaps one thing that can undergird and kind of anchor us in a conversation about anti-Blackness and abolition and the criminal justice system is the structures that need to be put in place, and in particular, the structures that need to be put in place from the health system. And so it's with that I want us to center kind of my reflections on abolition, in particular, thinking about what it is, where it is that we're complicit in having perpetuated structural racism, where it is that we're complicit in anti-Blackness, and where it is that collectively we can move forward. And so what I am going to do is center my reflections with photos. I'm going to share my screen and then do something that I learned from my colleague Marcela Nunez-Smith, which is to turn off my video so that I can move through my PowerPoint. Okay, so can you see these photos? Super. And then I actually don't know how to share close my video, so I'll just keep moving forward. So what I wanted to do is first just to really kind of ground us in what it is, at least the criminal justice system is. And some of you have seen me share these photos before, but others of you may not have. And so, as Tracey has shared with us, COVID-19 has really unmasked yet again long-standing health disparities that are fueled by our nation's correctional system. The recent deaths of Breonna Taylor, George Floyd, and others have really highlighted persistent societal racism and especially anti-Blackness. And this is nowhere better illustrated in our criminal justice system. So just to bring us some statistics, again, the BJS estimates that over 6 million Americans, mostly the poor and people of color, are currently under some form of correctional control. Tens of millions more are formally incarcerated. And so what I wanted to do is to share photos. Here are all photos from within San Quentin, which is one of the largest prisons in the United States. And it's the source of a huge outbreak of COVID-19. These, of course, are photos from prior to COVID-19, where right now about 1,600 individuals, both those who are incarcerated as well as staff, have COVID-19, as illustrating features of a second-tier healthcare system that exists behind bars, and really trying to drive home the point that while we aim to decarcerate and, quote, abolish the prison system, that what it requires from us as healthcare providers and healthcare leaders is that much more, to really abolish that which would prisons and jails as we see them, as they currently exist. It requires us to make some serious investments in the health systems behind bars. And so this here is a photo of a gentleman who's incarcerated, who's going to see his healthcare provider. And you can see that they're making the line to see a healthcare provider. And I just start by saying is that of the 2.2 million people that are incarcerated, about 80% have a chronic health condition that warrants longitudinal primary care. And you can see that this is how they're accessing the health system. There's another patient, if you look at the picture, he's in a cage waiting for the doctor. And so the system in and of itself, in their experience, the health system is violent in its making, that to wait to see a doctor, there's a person that's being held in a cage. However, it's important to remember that behind bars, it's one of the only places where we have a constitutional guarantee for healthcare. And so for the large number of individuals that move through the criminal justice system, and they estimate it's about 10 million each year, especially for adults, Black men in particular, it's often the place where they first access healthcare as an adult. And so 40% of individuals are newly diagnosed with a chronic health condition while they're incarcerated. And this is given a court case in the 1970s, which provided a constitutional guarantee, again, for healthcare. And then increasingly, as the length of sentences have increased, the focus has shifted from acute care now to the provision of chronic health care. This was a patient that actually had been newly diagnosed with hypertension while incarcerated. And I share this photo here as again, you can see that he'd been newly diagnosed with hypertension, had been sent out to a local hospital with hypertensive emergency. His blood pressures were sky high, and then brought back in, and this was kind of a post-hospitalization rounding on the patient. And so sometimes the very structures of the criminal justice system don't permit kind of the usual standards of care. You can see that we've thrown the blood pressure cuff through the window here. There's not a lot of space for confidentiality, for discussion of care. Moreover, this gentleman every single day has to make a line to see a nurse. And he's called up at the crack of dawn, goes to see a line to get his medications, to see a nurse. The nurse gives him his medications for his high blood pressure, and he takes it. She checks to see if he's cheeked it, and then moves back into his cell. And so if you think about kind of how it is that we teach our patients to take care of their chronic health conditions, you know, adherence is almost 100% in corrections. And interestingly, the management of chronic health conditions is actually better behind bars than it is in the community. However, it's incredibly passive. The other thing is that for patients with diabetes, if you don't comply with your diabetic regimen, in studies that we've done in Connecticut and in other states, in certain circumstances, if you say don't want to get your insulin for the day, you're actually sent to administrative segregation or solitary for not complying. And so again, the experience of healthcare is mandated in certain ways. It's incredible, you know, there's the capacity for patient adherence, but it can be incredibly punitive. This is a photo of patients waiting to see, in fact, an HIV doctor while incarcerated. And I point to it just to point to this pink slip. In many places around the country, still this is happening. This pink slip is a chet that you fill out. And patients, when they want to see a doctor, they have an acute need, have to fill this out. The chet is looked over, is looked over by, it's a kite, sorry, looked over by a correctional officer first. Then the correctional officer, if they think that there is a medical need, it's then looked over by a nurse, and then finally by a physician. And so again, there's, while healthcare is constitutionally guaranteed, there's real barriers to actually accessing healthcare. And so you can imagine that in the time of COVID, if you're having symptoms, and if this is the symptom of access, system of accessing care, it's nearly impossible to get good, timely care, or at least you have to go through a correctional officer to get access to care. And then lastly, I share this photo of a patient that was incarcerated in San Quentin, a gentleman, just like the first photo that I shared at the beginning, almost 70 years old, oxygen dependent with COPD. And what you can see here is that he is being held in administrative segregation, so solitary confinement. He spends 23 hours a day right now in this cell, and you can see that his oxygen is actually held outside of his cell. Every hour or so you would hear him as you walked by. Healthcare providers, correction officers would hear him bamming on the door, and it's because the tubing for his oxygen got kinked and he could no longer breathe. And again, you know, this picture for me illustrates the ways that our health system are brutally violent in its construction, and in particular within corrections, that healthcare isn't seen as primary. In fact, they think about the safety first and punishment first, and so the oxygen tank is being held outside. And again, for the millions of folks that are incarcerated, and then in particular those that have COVID now, how is the healthcare being delivered inside? Where is the oxygen as people are being held with COVID symptoms? And thinking about this, you can see how folks who've been diagnosed with chronic conditions, who first experience the healthcare system behind bars, may be mistrustful, distrustful, or find the health system, you know, abhorrent, given these experiences. The other thing that I would want to point out here is that we do have this whole constitutionally guaranteed system of care behind bars, and also, and taxpayer dollars, each and every one of our taxpayer dollars go into paying for the delivery of care. But there isn't, say, a JCO, a system that monitors the quality of care behind bars. And so essentially there are these 2.2 million people that are incarcerated, and an even larger population that move through a health system for which there is limited federal oversight, and certainly no transparent ways of measuring quality of care delivered inside. And so this picture comes from Cook County, and you know, it was in the media recently during COVID-19, and a person that's incarcerated wrote, you know, on a window, "Help, we matter too." And, you know, it's inescapable in the news that about 39, I think, of the 50 largest outbreaks in our country for COVID-19 are in correctional systems right now. Again, this is Cook County, and then right now in the news is San Quentin. And so the response has been, I think, really importantly, advocating for the early release. And so Importantly, and I could show the figures, but Connecticut is an all-time low in our state right now of who's incarcerated. California's Governor Newsom also just announced the release of 8,000 individuals. And for those of us that believe that prisons and jails are health harming, that decarceration is really important, this should be news that we celebrate, right? That if you're thinking about kind of how it is that we deconstruct and improve the health and well-being of our communities, decarceration is critical. And I do want to then point out, though, that the early release of incarcerated people actually can endanger lives. And I think that this is important to say out loud, and really it implicates kind of what it is that we do within community health systems. So each week in clinic, as Anna referred to before, we here in New Haven, and this is a picture of our team, Lisa Puglisi, she's an internist, Jerry Smart, one of our community health workers and a patient of ours, take care of people that have come home from prisons and jails in Connecticut. And this is a program, again, among many across the country that are really focused on targeted care. And what we can see over, and I've been doing this for decades now, is that the return home from prisons and jails is nearly impossible. That in fact, in spite of how bad healthcare is inside, the construction of it, people's chronic health conditions actually worsen following release. The rates of dying from overdose, from heart disease, cancer, gun violence, suicide actually are incrementally higher following release. And so what we see in clinic are barriers upon barriers where patients actually don't have safe places to stay, can't get food, can't get jobs here in New Haven. And this has been augmented that much more during COVID-19. We've worked hard to kind of slowly, iteratively, and incrementally build in the systems. How do we get folks phones, for instance, right? To actually be able to do a telemedicine visit. What if they've never had medications? And if they live in a city in Connecticut where there isn't a transitions clinic program, how do we get appropriate access to the medications they need, to the discharge that they need? And so I guess the point that I really wanted to kind of make with my reflections here is that so much of the energy and enthusiasm around kind of decarceration and abolition is really focused on defunding these kind of hanging our hats on just this one moment in time. And to me, what undergirds kind of the work that we need to do to really, quote, abolish prisons and jails is the work that we need to be doing in the health systems. How do we provide the vital supports that are needed? Do we really welcome our patients that come from these correctional systems that are kind of, again, this second-class system of healthcare into our community health system? The medical students raised important points, and I think, just thinking about, and this isn't a photo from the primary care center, but all over Yale New Haven Hospital, is this welcoming to have a person that's armed in our health system? How does that make our patients feel, right? Why is it that we have Medicaid to terminate when people come home from corrections? How can we create systems that are more embracing of patients that are coming home from these correctional systems that are so structurally violent, and how do we make our systems less violent? And so the last thing I'd say is this, is that I had the opportunity to listen to the beautiful kind of 1619 podcast, and there was one episode focused, I think it was episode 5, on the healthcare system, and Tracey alluded to this, that in 1865 the Freedmen's Bureau became the nation's first federally supported healthcare system. And it was interestingly, when you tune into the podcast, it was created in response to outbreaks, again, in infectious diseases. So, you can think about the historical parallels of dysentery and smallpox at the time that emerged after emancipation. So it was concerns about the community that then this healthcare system was born. However, it was structured such that there was 100 physicians taking care of the 4 million previously enslaved workers who were now largely without housing, food, employment. And, then they also had incrementally high risks of dying compared with the general population. And so to me, thinking about this moment in history, and I really do think we're in a moment, like it does excite me. I've been doing this for a decade more, that there is mass, larger scale decarceration going on. But for this to be really successful, we have to interrogate ourselves, what it is that we ourselves as providers, but even more importantly, as systems and as communities are doing to scale up the health systems that are needed to provide these vital supports.
Thank you so much. I think we now have Sydney Green. Let's discuss it.
Wow, so thank you so much to Dr. Wang and Professor Meares. Dr. Wang, I really appreciate you sharing those photos. I think that especially in this moment with abolition being all over social media, and it can feel like a very abstract thing, and we have to remember that we're talking about real people, real families and lives. And so I really appreciate you bringing that to us today. And Professor Meares, again, I really appreciate you bringing, both of you brought a historical perspective, but I really do appreciate you really connecting this moment. As we use abolition, it's a historical term, and we have to remember that we're not done once this system is so-called abolished, but that even as we think about reconstructing or reallocating funds, we have to remember that the threat of anti-Black white supremacist violence is there, and that we can't be passive in this moment. We have to remember that there's going to be something that comes next. And so I really appreciate both of you for that. I wanted to first just contextualize how I came into consciousness, and I want to invite both of you to reflect on that moment for yourselves as well. So when I graduated from college, I'm originally from Florida, and I moved back to Florida, to Tallahassee, Florida, and this was in 2013, around the same time as the Free Marissa Now movement. And so Marissa Alexander, for those of you who don't know, is a Black woman who at the time was facing 20 years in prison for firing a warning shot in her own house, in her own garage, to protect herself from her husband, who admitted on tape in a court deposition that he not only abused her, but that he would have killed her if given the opportunity. And this was also just after Trayvon Martin was murdered, and his murderer, whose name I'm just not going to use, was able to get off on the Stand Your Ground law. And that law was not applied to Marissa Alexander, a Black woman's situation. And so she successfully appealed, and then the state attorney at the time, Angela Corey, essentially said that not only would she retry this woman, but she sought retribution. And so instead of giving her, if she were to sentence her 20 years, Marissa now faced 3 consecutive 20-year sentences. So she would have been in prison for 60 years, and she had potentially 60 years, and she had children. And I was just very frustrated that pediatricians, for example, were not talking about how awful this would be for her children, or OBGYNs talking about how putting someone who is immediately postpartum into prison was not something that would be health promoting. And so I really latched onto this movement of, there really is no case where police are okay, that putting people in prisons and jails are not okay, not in the system that we have now. And so I kind of shifted my research to really be thinking about how the health system is really implicated in a lot of what is going on, and that criminalization and this term carcerality is not just limited to jails and prisons, but it's how we treat people before they get to that point as well. And I want to kind of just connect that to an article that came out in 2017 in Pediatrics Journal that was promoting the use of a new algorithm. And this algorithm would allow pediatricians to predict whether their teenage patients would be future perpetrators of intimate partner violence in order to funnel them into these intensive prevention programs. And not only was this article published in Pediatrics, the leading journal, but the editor of the journal wrote a perspective piece lauding this paper. And so I really want us to kind of, as we go through this conversation, those of us who are in healthcare, who are training or otherwise already providers, to really think about how we are complicit in this, and that as you know, the abolition movement, the defund movement looks to send funding to our way, send funding our way to, you know, whether it's mental health or some other reason, we have to make sure that we're doing the work to ensure that we are not recreating the same systems that we claim to be abolishing and defunding. So I'm going to stop there, but I just want to again thank Dr. Wang and Professor Meares for being here and really starting this conversation for us.
Thank you all for such eloquent and profound reflections, and only opens up more questions for us. I see we have one question so far, and then I have some questions as well. But let's start with the one that was submitted. My remarkable colleague, Dr. Ayanna Jordan, made a call that we should avoid the term criminal justice system, since the system is hardly just, and instead call it the criminal legal system. I'm interested to hear what the panelists think of this and how we might best be ambassadors of changing this language in a widespread way. So we'll start with that.
I'll jump in. I think I actually referred to it as the criminal legal system in my remarks. I think that that's fair. That's a fair description. But if we're really going to break the term down, I don't think we'd even call it a criminal legal system, because it's not a system, right? So really, it is you know, a set of criminal legal processes, and I think, you know, the questioner says, well, how can we, you know, make this change? I think increasingly, if you look at what folks are writing in my field, and even in public writing, a couple of op-eds I just wrote, you know, I've been using that term instead. I think it's an important thing to say, but lose the conjunction, period. It is also the case that it is critical for people to understand all the ways that how we talk about this set of issues and institutions that lead to the consequences that we were talking about, and that Emily Wang gave us such incredible photographic evidence about, is not what we think it is. And to the extent that it's systematic, it is not systematic about delivering justice. It's systematic about reinforcing the system, which that is a system, of racism and inequality.
You know, I'll echo this, which I think that, you know, language is really important. And, you know, how we define the system, you know, I appreciate Ayanna, and really thinking about kind of not using even the term justice. I also, much of what I think we can work on in our own worlds is also in stuff that we work on within, you know, the work that we do in our lab, but also even the NIH recently, NIDA has used person-centered language to stop using kind of terms like prisoners, inmates, instead using people with histories of incarceration. These are kind of important ways that you do start shifting narratives of people that have been incarcerated. And I just tell a story, which is to say, within EPIC, oftentimes you'll note like how people write and describe individuals, of course, really does influence the care that they receive and the care that we deliver. That I've often seen notations where, people have, there's actually a critical warning list of a sex offender, right? A sex offender. And, I bring up kind of an extreme case to illustrate my point, which is that, not being a legal expert, I will just say this, though, that there are many ways by which you are convicted of a sex offense. And those include, from the extreme version that are presented, that we can all imagine, to ones of, 14 years old having sex with another teen years old, right? And so the importance, though, that of our own healthcare system labeling people in the health record and how that perpetuates other narratives, I think is critical for, again, abolishing the impacts, like ending prisons and jails, and then also creating the systems that then support the people that have been incarcerated. That language is critically important.
The question about how not only to avoid the term justice where it's not merited, but to work towards something else calls into question, what is the something else? So you've all talked about abolition in really compelling ways and the fact that our current approaches are not just at all. Can you say something about what we're working toward? What would justice look like in a better universe that we're working toward? And also, how would crime be handled? How would we think about crime? I'm sure that's a question that people have.
Want me to go?
Yeah, the crime one. I'm looking at you, Tracey.
Yeah, well, but I think that's part of the same question, right? Talking about crime is answering the question about what replaces it. And again, I think what replaces it is the set of public goods to which every citizen is entitled. Averting crime is part of that set of public goods, and there is a set of public goods that is necessary to avert those things. And it turns out that people who are experiencing high incidences of violence in their neighborhood, plus the state's typical response to that violence, which is often excess from the state, can articulate very clearly what it is that they want. So I have a project. If you go to the Justice Collaboratory website, you'll see a project called the Portals Project. We also have our own website, portalspolicingproject1word.com, in which I, along with political scientist Veshel Weaver and our grad student Gwen Prowse here at Yale, have curated a set of conversations among residents of the cities of Baltimore, Newark, Chicago, Milwaukee, Los Angeles, Mexico City, where they're talking about their experiences with both violence in their neighborhood and police. And, they talk about what they want in their vision of safety, right? Now, maybe what they don't know exactly how to do is how to get there, like what it is that the state is going to do to ensure that they get those sets of public goods that they need. And the governance project is difficult. It's made more difficult by the fact that we've invested in a certain set of responses that don't look anything like the set of public goods to which people are entitled. But to say that we don't know what it looks like, we know what it looks like. We do. This is not hard. What's hard is that it requires many people to give up things that they're not used to giving up, including privilege.
I'm going to answer that question in a different way, but which is to say, what does it look like? And having worked in a health system, it's not what it looks like in our health system right now. It just isn't, right? It's not what it looks like in almost any health system in this country. And so that's just point one, that I don't want people to leave this saying that, oh yeah, just the health system's the solution. Let's just shore on up. We know what we're doing, because we don't. That's one. Two, I do want to just emphasize Tracey's point, which is that in our work, we really do try to center the perspectives, needs, and values of those who've been incarcerated in our work. And time again, there are solutions that already exist, that are grounded within those communities, that are important, and they're ones that do require shifting of power. And the kind of most concrete solution, and it's centering Black folks in particular, in this, is the hiring of people that have assets and skills to work in our health systems as community health workers, right? So, just most fundamental level, you're like, okay, it's getting a job, and it's an important job. Likely, often in our network, it's to a person of color to work in our health system. But then it also shifts how the health system forces kind of employment policies, practices that are really racist in their construction. It also changes kind of the physical look of who works in our health system, that these are experts that we value. And it's in that inclusion of those individuals, the changings of the policies, that we see a less racist healthcare system. And so to me, part of this work is really centering the work that we do in the health system, the work we do in our research, the work that we're doing historically around kind of narratives that were never told, that are never involved, included in the health system space, and finding solutions that exist there. That to me is part of our way forward. What that looks like, look, I've not been incarcerated, but I am surrounded by people that have been incarcerated, and there are solutions to be had.
Thank you. I think you've begun to answer the next question, which is how can legal and healthcare experts or service providers support needed economic reforms, abolishing existing economic arrangements? But I wonder if you would both like to expand on that, and perhaps even add something from your own work as legal and medical scholars. How do you approach these tasks in your own work?
So I'll start just because I'm unmuted. So I'll say that, and I might be misquoting, so, but when I last looked, 1 out of 6 new jobs in this country are in the healthcare sector. 1 out of $3 for our GDP are from the healthcare sector. And so to me, some of what we can be doing mostly is hiring up. And that creates economic opportunities. That might feel really incremental, but I think it's really critical to just say that out loud, that in New Haven, where the unemployment rates are high, especially in certain communities, and where the top 3 employers are the university, the health system, and the medical school, what are we doing to hire up? How do we support? And so this is real concrete. The second is the community investments that the hospitals have to make really have to be focused and targeted. It's not to any old community service agency, but targeted kind of with a health equity, anti-Blackness frame in mind. And those are ways that you get dollars into communities. It's the engine that runs our community, right?
I'll just add a couple of other things. So the Justice Collaboratory, of which Emily is a member, is an interdisciplinary research center that we focus. Our motto is serious science, serious impact. So we do a lot of basic science to interrogate and advance, theories around how members of the public understand the fairness and legitimacy of different legal authorities, including police. That's where we've done most of our work, but not exclusively. And those theories apply outside of the of institutions that process people through what we call the criminal legal system. It's applicable to corporations. It's applicable to public schools. My colleague, Tom Tyler, has written a book called Why Children Follow Rules. It's relevant to those of you who have children and who parent, right? It is a theory of general applicability. And we have taken that science and developed policy that could be used in different agencies. We've developed trainings for police agencies. We have translated it to model statutes. We just started a clinic where we hired someone, very able person from New York City, who's actually going to be developing a bunch of model legislation that we hope will be adopted by states all over the country so that these policies will be adopted in municipalities and so on. There's lots of different things you can do, and we have to do all of them. Actually, you know, when you're talking about the kind of advocacy that the questioner asked, it requires actually wholesale re-engineering of the legislative structure that underlies these systems. So let me just give you one example. Most policing agencies in this country don't have any serious enabling legislation. So think about something like the Department of Labor. You can look in a state statute, in the Connecticut state statute, you can see the enabling legislation of that department that says what it's supposed to do, says what its constraints are, says what the rules are that actually regulate it. You're not going to find anything like that for policing as a general matter. Another thing, you'll hear in the news that there are something like, depends on where you read it, 17,000, 18,000 different policing agencies. I'm focusing on policing because that's what I know best, but we can have a similar conversation around different institutions. It is not the case that we actually know that there are exactly 18,000 police agencies. That's a guess. It's an approximation. We actually don't know. And that is because in this country, the federal government doesn't require policing agencies to be accredited. It doesn't actually require agencies to report to the federal government, their activities. There's no auditing mechanism. The Department of Civil Rights only gets involved when there is a pattern and practice of constitutional violation. Go to any other country in the world, in Europe, you would not see that, right? And so, when you talk about, are there things that we can do, there's so many things and so much that can be done. And that is necessary to do if we're going to make a change.
Thanks so much. So we have two questions that seem to go together, and I'll just take a moment to read them both. When we look at the history of this country, the current system in place is rooted in the dehumanization of Black, Brown, and Indigenous bodies. The system is not only the result of overfunding, but it is supported, I assume, of carceral system, but it's supported and perpetuated by individuals and groups. How can we work to prevent these groups from continuing to perpetuate these systems, even after we defund, abolish these detrimental systems? Then the second question related to that, can you address the anti-Blackness ideologies that come along with the white supremacist crushing of Reconstruction? The idea that Black people are criminals, are lazy, are inherently unworthy of citizenship and basic human rights is deeply entrenched up to the present. Seems to me this is a big obstacle for carrying the abolition and defunding conversation forward. So it's not just coming up with policies rooted in justice, but convincing a good number of white people, ordinary citizens and politicians, that BIPOC deserve justice. How do we get there? Very small question.
Can you repeat the sentence about it's not just justice, but
okay.
Yeah.
It's not just coming up with policies rooted in justice, but convincing a good number of white people, ordinary people and politicians, that BIPOC deserve justice. How do we get there? That
is a conversation that's rooted in justice. Like the writing of that actually, to me, I don't understand that phrase to say that it's not just a conversation rooted in justice, because justice actually requires ordinary people to understand that the air that we breathe, the structure of the system, and I'm not talking about how the criminal legal system operates, the structure of what we live in is unjust and has been unjust and continues to be unjust. That's the work. I actually think the answer is embedded in the questioner's question, but by rearranging the words and saying it's not just that, actually it is just that, in my view. And I don't mean to put the questioner on, you know, I'm not trying to cast aspersions or shade or anything, but that's it. A social psychologist, you know, my dear friend, also a Justice Collaboratory member. Yes, this can be the advertisement for the Justice Collaboratory. Jen Richardson would say that that is the work, and the work that people like me do is really to push against the air that we breathe. You know, it's the psychologists of race and racial injustice who can pinpoint the dynamic that the questioner is discussing, right? And we can do all kinds of work to point out the most egregious instances of this dynamic. But until, you know, the aspects of the world that we live in that people, many white people don't notice or don't acknowledge or aren't willing to work to changes, then yeah, it's going to be really hard.
So I'd love to open this question up to Dr. Wang as well, but I'm thinking that the questioners are interested in any examples of strategies or languages or techniques that you and your colleagues have come across that help to broaden support for this movement.
That's interesting. You mean in particular for, you know, we've tried it all. I mean, you know, any way possible. And it ranges from kind of at the individual level. You know, I can just give you really concrete stories, which is to say that most people in our white or healthcare communities, you know, wouldn't necessarily even know, you know, a person that's been incarcerated until a person like Jerry Smart comes along and he's well dressed and looks good. And, you know, I hate to name him, but he is the first in New Haven. And then they're stunned that he's been incarcerated. And then they're like, you know, whispering on the side, oh, he's been incarcerated. And they look him up and then they realize, like, have more interactions with him. He has a son. And it's till the mixing and literally having to interact that these conversations start to change. That's on the individual level. Then on, you know, kind of the next level is trying to make arguments that are principled in costs, human rights, you know, like what is it, the health disparities, how it is that kind of improving all our health also has to improve, like the very fundamental nature is that having kind of a more equitable health system helps us all, period, punto, you know, end part. I mean, I think we've tried all sorts of different strategies, but I do think at the root of it is, to me, you know, we have study after study after study after study, and Lord knows we've thought about study after study after study after study, taking a cost lane, a human rights lane, you know, again, trying to think about interventions that are asset-based, getting NIH funding, whatever it is. And to me, when, you know, the hearts and minds of ordinary people out there start to shift is once they've, you know, at least in my experience, start meeting and talking to and really kind of humanizing and changing the narrative of Black folks, you know, and that is not an easy task when we live segregated lives, period. And in the health system, you know, it's just obvious, it's abundant.
You know, I'd like to say just one other thing, since I invoked Jennifer Richardson, who has a new piece coming out in the Atlantic Monthly, the print version of it. So it's going to be out pretty soon if it's not already out. But one of the things she writes about is the myth of racial progress, right? And the idea that, you know, things are better we've been focusing primarily on Black people. So I just want to take a moment and say, you know, that a lot of the issues that we are discussing today are not exclusive to Black people or specifically descendants of enslaved people, as I am. It also is experienced by brown people and Asian folk and in this country in particular, natives and indigenous people. So I just want to point that out. But anyway, the social psychology, that research focuses primarily on Black people. And when we're talking about the myth of racial progress, that's what she's talking about. And one of the things we find is that when whites in particular are given evidence about racial progress, instead of understanding the extent to which how bad things were in historically, they actually revise their understanding of history such that they come to conclusions that the situation historically wasn't as bad as they thought, which provides less of an impetus to do the kinds of things that are necessary today to create true equality. And the reason why that's important is that, you know, when folks are asking about things they can do, and I think this connects up with what Emily was saying about studies, it suggests that there are, well, if we could just do this one thing, or if we could in our NIH applications, the thing that you and I were talking about a week or so ago, Emily, you know, do the thing where we have another person of color or an underrepresented minority added onto our grant, or if we could just have slightly more, diverse professoriate in the medical school. If there are like, you know, these little things, then that's all we need to do. I don't want to make light or say that those things are not important to do, because they are. But those are little things that you do to respond to the systematic situation of profound racial injustice that we have in this country today, and we've had for a very long time, that is really not going to be undermined until people stop being, first of all, recognize that reality, and then stop engaging in actions that continue to support it. Because everything else is like remediation.
Yeah. I think I just wanted to add that I think it also takes, I mean, people are asking about on the individual level as well, and it takes reframing the way you talk about these things, right? And so, you know, I mentioned earlier about not being passive, but being like active about things, and not picking on the person who gave the question, but I'm just using it as an example because it's a concrete example. You know, think about the difference between saying that Black people or Black Indigenous people of color deserve justice, and saying that they've been denied justice, right? That this is an ongoing action, and that the positions that people are in, particularly Black people, Indigenous people in the US, they're not there because they're innately find themselves there. That the situations are not inevitable, but they're based on a series of decisions and ongoing decision-making, both historically and presently, that create the spaces that we're in. And so if you think of it as that kind of like ongoing, living, breathing history, right? It's not just something that happened and ended, that you can put yourself into that, and that you are a part of that. And every decision that you make can also shift in whichever direction you want it to go in and a direction you may not want it to go in. And so just being cognizant of that, it's not something you can like, all right, I shut that book and that door is closed until someone asks me about it again, but it's a part of every small and large decision that you make.
Thank you.
I'll echo that, Sydney, which is I do think, like, Lord knows, I think about kind of actions that I've made, big and small, that, you know, have repercussions over a lifetime, and it's just iterative, right? But this is what we've got, right? It's just making decisions over and over again, some that are bigger, some that push forward, but always having kind of um, an anti-racist, and increasingly more so how it is that you move through this world. So, you know, it's the frustration about the diversity supplements, and we don't have to go there, that Tracey and I were talking about, which is like, what a joke. And yes, of course you'll do it. So anyhow, thanks for that, Sydney.
Thank you. Actually, there are two questions that I think go together because they refer to the intergenerational impact of incarceration and violence. So the first one is, based on Sydney's comments about women and postpartum, can you both speak, and I'd also like to invite Sydney to speak, about one, pre-postnatal care for incarcerated women and ways to support healthcare and family rights for children born in prison? How can we address work toward equality care during early childhood for children of the incarcerated? And then the second one, I would like to hear more about the connections between domestic violence as a means to incarcerate people, often victims themselves, and the intergenerational traumas created that perpetuate and uphold a cycle of incarceration. So all three of you, I invite you to reflect. Thank you.
That sounds like Emily and Sydney's bailiwick to me.
Sydney, go for it.
Okay. So I want to start by saying that initially when I saw, I think there were like documentaries about these kind of like childcare, daycare centers for women and children who are born in prison, I thought, wow, what a great idea that we can keep mothers and babies together. But then you step back and you think about what's happening, that we're saying that it's okay for women to give birth while they're incarcerated, that as long as we keep them together in prison, or in jail, that it's okay for a child to grow up in, at least for a small part of time, in a prison. And I think that 100% is not okay, right? It's kind of this like a Band-Aid issue again of saying that like, okay, we're going to keep people together, but why are we not pushing to keep people together outside of a prison, right? So I just wanted to say that because I think, especially in healthcare, that like we think of this idea, and Dr. Wang brought this up as well, but the idea that people who are incarcerated are the only ones with a constitutional right to healthcare. Instead of saying, let's think beyond just saying like it's great that people who are incarcerated can get healthcare, right? Let's think beyond, think about what we're saying when we make those comments. So I wanted to add that. In terms of the kind of intergenerational trauma, or people who become involved with the criminal legal system through domestic violence and sexual assault and any kind of other intimate partner violences. I think that there's a long history of women, particularly women of color, who have worked and advocated for this for women in particular, but I'm thinking like broadening that to cis, trans, and non-binary people as well, to not become justice involved because they are victims of a particular violence. And so I'm thinking of groups like Survived and Punished. We've seen women like Cyntoia Brown who end up being incarcerated because they retaliate against a perpetrator. And again, we want to think like, how can we be making it so that people are not even getting to the point where they have to retaliate, right? Yes, like there is trauma intergenerationally, but I think that we just sometimes take for granted that like, as we're kind of like putting Band-Aids and I mean, Dr. Wang, you work with people who have recently been released, and yes, those people need care, but I think that those of us who are not working in that situation, we can really want to push ourselves to be thinking like the steps that happen before that. And so like what a lot of these groups, they talk about, you know, that violence happens because there's something wanting in the community, right? And I think, you know, we should be thinking about that, whether it's education, whether it's jobs, whether it's it's healthcare, et cetera. So I'm sorry, I'm like kind of like rambling, but I think I want to just point out Survived and Punished. I want to point out Insight, which is women against violence against women of color, and Lee Goodmark, who's written a book called Decriminalizing Domestic Violence, which really goes in depth and from a legal perspective on what the alternatives can be for.
Great, Sydney. You know, I wanted to think about two issues that those comments have me reflect on. And, you know, I get that the person that wrote the comments was really focused on domestic violence, but I think violence, period, is something important to attend to. And, you know, even how, you know, going back to Jeanette's comment about how we demarcate language, and, you know, many of us, I'd say, especially in the medical community, are really okay with decarcerating quote unquote non-violent folks, like people that haven't committed violent offenses. And then within the categories of those that have been convicted of a violent offense, domestic violence, okay, that has the narrative of we're okay with this, right? That's okay. Maybe, maybe not, right? As Sydney's pointing out. And to me, I think, again, these wholesale distinctions are difficult and really are anchoring ourselves in untenable kind of solutions, which is to say, you know, to say that you're one for abolition, or thinking about you'll recognize that prisons and jails are health harming. And so we'll only decarcerate certain individuals, those that are nonviolent. It seems kind of, it is to me entirely antithetical, that we have to kind of come to a reckoning, which is to say that the whole system has been violent in its generation, that many of the individuals, the majority of individuals that have been convicted of violent crimes actually were victims of violence themselves, right? And so to kind of create these distinctions, I think are important to recognize, and important to recognize in our own narratives of how we think about ourselves as, you know, quote unquote abolitionists, right? Is that, to me, when I look at that, that connection is critical, not just for those that have been victims of domestic violence, but victims of any sort of violence. And these are the very reasons for why, you know, it's just not sensible as a doctor. You know, you put a person that has been a victim of violence into a violent situation, which is prisons and jails, and of course that begets more violence, which then begets more violence and more violence. So the first I would say is that I certainly agree that, you know, incarceration, it creates intergenerational violence in all sorts of ways, not just for women, not just for pregnant women, but for all. For men that have committed the most heinous of crimes, that were convicted and sentenced and have served their sentences. And we have to push our national dialogue to that not just thinking about the pregnant women who are there and their children, but all folks that are incarcerated right now, and how brutally violent the system is and the healthcare system is, one. And then the second is that, you know, of course, these are intergenerational issues. And so, you know, I kind of think these are going to be intergenerational fixes too, that it's not going to be a quick and hurry. You know, it took us, we had 40 years where we've ramped up. We've never done it well for communities of color, ever. And in particular for Black folks in this country, ever. So who's to say that a quick defund the police and this and shifting of the budget is going to do this? This is about the hard and nasty work that we all have to do of interrogating what it is that we do as healthcare providers, as students, as, you know, legal scholars, etc. And then getting down to work. And some things are going to work and some things aren't, but it is not going to be quick. It is intergenerational. I'm hoping, you know, for my kids' generation, it's their grandkids 100 years from now. This looks different. I mean, I'm hoping it looks different tomorrow, but, you know, realistically, I feel like those are the two things that kind of stuck out with me in those comments, which is that it's not just the violence of certain folks, but it's the system that's violent. And, you know, us kind of partitioning off for these people that have committed violent crimes is also harming kind of overall.
That's such a critical point, right? Such a critical point, because even if we change it and could snap our fingers and have the kind of policing we wanted tomorrow, you know, or if prisons changed tomorrow, or if, you know, prosecution changed tomorrow and the legal authority by which police are able to enforce arrests that leads people to incarcerative settings and so on changed tomorrow. An example of which, Eric Garner lost his life because he was subject to forcible arrest for selling loose cigarettes on a corner. Even if you think that that should be some kind of violation, why on earth should that be subject to forcible arrest, which leads to all of these things, okay? So even if all of those things change tomorrow, we're still left with the fragile, brittle communities today where there is poor health care, where there is low educational attainment, where there is inadequate housing, where there are essential workers making, you know, much less than anyone's minimum wage. That doesn't change tomorrow. Those places are still going to be places of concentrated violence. They're still going to be places that experience high rates of coronavirus infection. They're still going to be places of, we can go on, which means that changing, you know, getting the kind of policing we want tomorrow, we still have to deal with what we've got right now. And that's not going to be cheap, which gets back to these questions about who's sacrificing, what it's going to cost, and what we're all willing to do.
Just a tag onto the topic of intergenerational interventions and also multi-sector interventions. I hear you saying we need a comprehensive approach that goes beyond policing, beyond criminal legal system. There's a question here. Can you speak more about the intersection with education and incarceration? What can parents and communities do when thinking about school systems, pushing for change to prevent school to prison concerns and to get police out of schools? Also, pediatricians' role in school system in making sure children get appropriate supports that don't perpetuate disparities. Just while we're on this subject, any thoughts about that?
Yeah, actually, another member of the Justice Collaboratory is a professor at the Graduate School of Education at Rutgers. And we actually produced a couple of years, I think it's actually on our website, Justice Forward, where we talk about the connection between education and all of these concepts. So I'll give you a little factoid. People spend a lot of time talking about teacher quality, and it's the link between that and you know, children's attainment in schools. Critical, important. It turns out that some research shows that if we broaden the factors to look at all the things that are important to make sure that, you know, children get higher test scores and so on, there's some research showing that going to the dentist twice a year produces more impact on children's grades than, quote unquote, a good teacher. That doesn't mean, of course, that schools shouldn't care about making sure that teachers aren't as good as they can be within schools. But it does show, in the context of what you were talking about, multi-institutions, the kinds of things that we need to do to make sure that children have the best outcomes aren't just about what happens in schools, even though those are the things that schools have control of. It's also the case that kids and the public generally receive education outside of the walls of schools. So, you know, this Justice Collaboratory, remember I was just talking about Ben Justice, and I wrote a piece called How the Criminal Justice System Educates Citizens, right? This is the kind of thing that we need to be thinking about, you know, to ensure, making sure that people understand sort of the basics of, you know, the importance of what citizens deserve, you know, collective thinking, the fact that, you know, that there's not only one kind of capitalism, for example, basics of history, the fact that I started this discussion about the relationship between abolition and Reconstruction is something that people generally don't know. A lot of people learned about the race massacre in Tulsa through Watchmen, a TV show, right? I've lost the thread because I was getting worked up about, the importance of, education.
Just many sectors, including media, right?
Yeah, and this
media produces it.
But, we do know that having, violence in schools, whether it's having police doing that or, violence among the kids because the schools are located in violent contexts impedes educational attainment, which leads to a lot of the other factors that we were just talking about. It's interesting that, and I feel heartened actually, that in a conversation in the medical school, we have spent so little time talking about how to fix particular aspects of our systems to assign criminal responsibility. And we've had a really deep and wide-ranging discussion about inequality and structural inequality and, the importance of eradicating that to achieve citizenship. So I actually am feeling more hopeful than I ever have been in conversations like this because, maybe y'all in the healthcare system are looking at the right things compared to the audiences that I'm usually speaking to.
Thank you. Any reflections from Dr. Wang or Sydney Kveen? No? If not, I'm going to put together two questions that really seem to bring this home, because I really appreciated the speaker's challenge to us to bring this right home. What are we doing personally in our work and our community life? So the first is, what is Yale New Haven Hospital going to commit from this perspective? Is Yale New Haven Hospital willing, open to collaborating with transitions for employment, leading to fair pay and benefits, especially for healthcare jobs labeled as quote unquote low skill? So that's one. And then the second, as abolitionists, Miriam Kava tells us we cannot advocate for or participate in any activity that strengthens the legitimacy of the prison industrial complex. So as abolitionist healthcare providers, how can we provide healthcare to incarcerated people within the prison system without further legitimizing it? Any thoughts?
That cuts to the core, that last question, the core of the core for me. And I just so appreciate that question because I think it's a daily struggle in my life. We've made decisions again, and there's the personal decisions and kind of professional ones we've made as a team. And so I'll go to the professional that's easier, which is to say that, as a network and as a lab and as a center, we again have centered the values, needs, and preferences of people that are incarcerated. So have made concrete decisions in partnership and in collaboration, which includes we don't take direct funding within transitions from correctional systems. We really work up against reinforcing kind of, again, systems of control, surveillance, et cetera. And, a real concrete way of describing that is like, asking our advisory boards over and over again, urine toxicologies, how do they feel about that, even if the clinic system? And, interestingly, the discussion is actually different than we might experience. So again, my point is just centering, again, our policies and practices around their values, I think is critical. For myself, this is kind of, I'd say, what I think about all the time is, and I think, you only have 24 hours in the day. How is it that you kind of bring your best self to this work and push it forward? And I think the really hard struggle that we have as healthcare providers is this real fact is that there are patients that are incarcerated right now that without healthcare providers being inside, they're stuck, they're screwed. There's no way moving forward, you know? And so I have kind of the deepest, I'd say most radical of colleagues that are practicing inside that see this as an important part of abolition, you know, of the provision of healthcare inside, if provided well, is a path for decarceration. The provision of healthcare is a way of affirming someone's humanity inside as a path for abolition. And that said, I think that this is really very, very complicated. I mean, I saw that the APHA came out saying that now there's kind of statements yesterday where they are no longer in partnership, no grants, no funds, nothing with the police. And they distinguished the police from prisons. This is the American Public Health Association. And to me, that's complicated. It's deeply complicated. And speaking as someone that works mostly with prisons and jails, how do you create a transitional program? How do you create unified electronic health records? How do you improve the care of those that come home? We're doing worse than, you know, the data show that. And so to me, I think that that question, I just keep pointing up to the top of my screen because I see it right there, is at the core kind of the values that undergird you. I don't have an answer to that, but I really appreciate it because it's that, I think that motivates, you know, why any of us do this work.
So Sydney, you're gonna have the last word on this one?
Oh, no, I'll let you have it.
Well, I was thinking we have 2 minutes, so I'll go quickly to make sure that you had the last word. I noticed that question in the Q&A, and I think my reaction was that I understand why someone would ask that question. I understand the motivation for quoting someone like Mariama Kaba, but I actually think her own work, Kaba's own work, actually shows how someone could be convicted with respect to that approach, but do things that other people would view as legitimizing current structures. Because if you look at things that she's done, it's not as if she would never, ever speak to police as they exist now. That's not what she has actually done in her own work, if you look at it. That's not to say that in working with them in some way that she understands herself to be legitimizing them. I'm saying that somebody looking at her from the outside could say that. And I point that out to say that I don't think I have ever been an idealist. I'm from Chicago, and Chicagoans are sort of famously pragmatists. And I think that if you are going to get things done, you are necessarily going to make some choices that others who have a different form of understanding their own ideals, you know, would criticize. And making that claim, I'm not saying, you know, get your hands dirty. And, you know, I'm not trying to be sort of, you know, there are these things that you should do that are bad or illegal. That's not the point. I think about, there are many examples, abolitionists, you know, Frederick Douglass as an example, who would do things that many idealists would say were clearly consistent with their ideals, and then he would also do things that people might look at and be a little bit like, oh wait, that's not a pure abolitionist approach. I just don't think that there's any purity to this if you're actually on the ground doing the work. You know, the people who can be the most pure are the people who write about it. And that's fine. And that's great and important. But I think if you're actually there on the ground doing something, that it is impossible to make a move that someone cannot ultimately criticize. And understandably so.
Thank you. And now the last word from Sydney Green.
I'll be super short. I just want to speak specifically to trainees and medical students. Don't wait. you're not going to get more power than you have right now as a medical student. They need our labor. And so as a collective, our voices can be just as powerful. And I'm just excited for, so many people joining this call. And thank you to Dr. Wang and Professor Meares for really educating us today and sharing your time with us. I really appreciate it.
Amen. And thank you, Sydney Green, as well as Tracey Meares and Emily Wang. Thank you so much. It's been a wonderful night.
Thanks, everybody.